Okay, and this is a nice segue right into our update on COVID-19. And Dr. Farnatano, I would love you, as part of your remarks, we did have one speaker speak to the medical benefits of some drugs that I know do have some medical benefit in treatment, but we shouldn't just be expecting everyone to be treated with the same drugs. So I'm hoping in your remarks you'll talk about the drugs that we are finding helpful under medical supervision that have been beneficial, such as remdesivir and other drugs, but the same drug doesn't work on every person. It has to depend upon your symptoms.
I'll cover that when it's my turn to speak.
Okay, well, and so we will start out then. Anna, do you want to lead off then today, and then we'll move on to Chris?
Yes, I'm just checking. Can you all hear me?
We can hear you well. Thank you, Anna.
Great, thank you. Thank you, Chair Anderson and members of the board for having us again today to provide an update on COVID-19. Overall, what we're going to cover today is just very quickly go over the current state, both in the state of California, as well as here in Contra Costa County, talk a little bit about hospitalizations, talk a little bit about our website, and Dr. Farnatano is going to go over the testing and tracing, as well as the sort of looking at the current orders and kind of looking forward to what orders are kind of out there, particularly as it pertains to schools. So as of today, the state is reporting 466,550 cases of COVID-19, and with sadly 8,518 deaths from this virus. In the state is quite concerned, and as we all witnessed with the governor sort of imposing some state mandates, but also the state is has started to monitor particular counties that meet sort of crossover certain thresholds. This is called the state monitoring list. And this is really a way for the state to track and target public health responses and effectiveness of the public health mitigation strategy. And I just wanted to stress, we were talking earlier about kind of how widespread COVID-19 is. Currently now, 93% of the population that lives in California is living in a monitored county. So those are all kind of like closely watched counties because they're seeing rises in important indicators. We are currently one of the counties who is on the state monitoring. We've been on that list since July 5th. And we are on that list because the number of cases, positive cases per 100,000 people in our county. And the last time I talked with you, we were on July 18th, there were 189 cases positive per 100,000. And as of yesterday, our 7-day average was 109 per 100,000. So we're headed in the right direction. Our goal is to get less than 100 per 100,000, and we're making progress toward that. And we hope to see that dip down in the next few days. So we'll be watching that closely. When I was here last on the 14th, we had 5,187 cases. And today we have 7,304 cases, which is an 1,886 rise in the last 2 weeks. Sadly, we've lost 108 people to this virus in our county alone. 70% of the deaths, and I heard it mentioned earlier, have actually occurred or are from people who are living in long-term care facilities. These are some of our most vulnerable residents, and most of whom have been quarantined since March. So I think the discussion we were just having was really important because it's not them going out and getting it, it's coming into them because it's moving through our community. So I think that was a really great discussion that we just had. We're working diligently to prevent the spread in these facilities, but we know that they're at very high risk as long as community spread is happening. Currently, we're following 27 outbreaks within these kinds of facilities. So as we talked about, we continue to have growing evidence of widespread community transmission with our highest case rates in our low-income communities and more diverse communities. The current percent positive, we've talked about this a lot. That means the number of tests that we are conducting per day, how many of them are actually positive. It's just under 8%, which is better news than the last time we talked to you where it was just over 8%. But our goal is to be less than 5%. We're seeing a consistent increase in the number of people who are in hospitals in our county. So currently we have 931 people in the hospital throughout the county. 105 of those are for COVID. And currently, and another, again, just remember, when we track the hospital capacity, it isn't just about people who are getting treated for COVID-19. Other things are still going on throughout the county. So it's really important, though, even though we hear about people talking about small numbers, just everyone else is still needing the other kinds of care. If they're in an auto accident, stroke, cardiac care, those things are still going on. Currently, our ICU utilization, or the amount of ICU beds being used in this county, is 74%. That's sort of that we're moving into a high mark there. And 40 of those are COVID-19, being treated for COVID-19. We have a total available of 1,600 hospital beds with a capability to surge. Surging is sort of a, last resort situation, but we do have surge plans in place, and those have all been vetted through our EMS and through our county health officer, as well as the health department. We have 4 people who are hospitalized in our county that are not residents of Contra Costa County. And we also additionally know of at least 16 people who are Contra Costa County residents who are hospitalized in other counties. Not all the hospitals have been consistently reporting, so that number actually may be higher. We may have residents that are hospitalized, more than 16 that are hospitalized outside of our county. But generally speaking, that number has been fairly consistent. We've always had at least over 10 people hospitalized in area or neighboring counties. Currently, we have, this is a really important caveat. There's going to be some changes. So for those of you who have been tracking the website, and I know there's many people who really have been focused and keeping track of all the specifics on our website. An important caveat coming up is currently we have 272 beds, ICU beds listed on our website. But of those, 73 of them are specifically for neonatal care. So you're going to see some modifications in the data in that we're going to pull out those 73 and start to list you the 199 remaining beds and the percentage of those that are being taken up, because the neonatal beds, they're not interchangeable. Adults cannot use those beds. So those really aren't available ICU beds. And this is sort of we're starting to refine our data gathering and our tracking. And so we don't want to have this false sense of security that we have, these beds that are really, they're set up with entirely different equipment, entirely different trained staff, and would not be of use for us for adults experiencing COVID-19. The other thing I wanted to just alert everyone is that on July 15th, the federal government mandated that the hospital data that has been historically reported to the CDC is now being reported to the National Health and Human Services. This has resulted in reporting delays and tracking of hospitalizations. And so when you see some of our data points, some of our graphs have not been updated, that is because we pull those data straight from the state, who pulls it normally from the federal databases. And there is a transition going on. We don't know how long this will impact our data. So I just wanted to, again, give that caveat. When you see some of our graphs that have not been updated, that is due to the federal government has now mandated a change in reporting, and we're not getting those data at the local level in the same time manner. We expect that to stabilize, but I just wanted to give that caveat for people that that's not happening at Contra Costa or even at the state of California. That's a federal impact. So we talked about the hospital beds, going up, and we're tracking that very closely. I just wanted to remind everyone that we do have alternative care sites, and we have reviewed all of our plans. We have plans in place to operate all of those care sites if needed. We have 396 beds available, alternative care sites, with another 100 coming online in late August. We also have a number of hotel rooms for both people who are under investigation, also known as PUIs. They can quarantine. They will qualify to quarantine at one of our hotels, as well as we also have hotel rooms, the health services through our Health, Housing, and Homeless Service division, as well as our Public Healthcare for the Homeless division, has integrated health and housing services across our system. And we have secured hotel rooms that have services attached to them. So if someone, and this is through the state's Project Room Key, for that we actually have over 400 beds available there, and as we're at 98% capacity, and that those folks who are in need of housing are not only given a hotel room, but what's I think the really great thing about Project Room Key is that they also come with a host of services that are now on site and embedded into the Room Key operation. And so both our H3 as well as our public healthcare for the homeless teams are moving in and out of there, providing service for those individuals. And finally, relating to homeless services, we also will be we plan to submit a Project Home Key. This is sort of the next step to Room Key, where we're looking at a more permanent housing, and that is really an application and a process that counties can go through to actually purchase hotels and then provide permanent housing for folks. So we will be submitting a Project Home Key application. We're going through a variety of steps through that process. It's a very rapid turnaround. So we'll keep you and the public posted on that. I wanted to, and I appreciate the conversation that everyone has had, and I know Chris is going to talk about some of the medications that are being talked about. I just know that we've heard a lot of information today, but the unfortunate reality is we still have no real mainstream treatment or even predictable treatment, nor a vaccine, which is why it's so important that we kind of take this long view, this broad view, and the discussions that we've had today, though we all wish we weren't here. These are really important things to think about as we move forward to both protect our community and to protect ourselves and the people that we love, and just the people around us. And that's why it's so important that just the 4 simple, key messages we want to impart on you is just wash your hands, cover your face, please keep space between you and others, socially distance at least 6 feet. And if you're not feeling well, please do not go out. Please stay home. We also want to encourage you to get tested, and Dr. Farnatano is going to talk about that. And we continue to recommend to employers in the region to please consider options to reduce contact and also to reduce utilization of public transportation as much as possible by having very clear, supportive telecommuting policies as well as sick policies. And so I want to I'll stop there and we can come back later for questions, but I want to hand off now to our County Health Officer, Dr. Chris Farnatano, who's going to be discussing testing, tracing, the latest updates on our orders for both the county and the state, and talk about some of the medications, I think, that are very commonly mentioned. So thank you.
Thank you, Director Roth. So I want to talk about our current testing situation, and again, cover the current treatments that are felt to be effective for treating COVID, and also give an update about schools. since there's been some changes around schools since our last board meeting. So Contra Costa County, like really every community now in this country, we are struggling to get our testing results back in a timely manner. And right now it can take as long as 2 weeks or even longer sometimes for someone to get their test results, especially if that is not is asymptomatic individual, someone who's not in a priority category. We at our public health lab can process a small number of tests and get those turnaround times in 2 or 3 days for key individuals who are symptomatic or essential workers or hospitalized patients. But that capacity is very limited. We've expanded that capacity, but it's still only a fraction of the testing that we need. So this is really a nationwide crisis. It has a lot of the flavor of the things we saw back in March and April, where the demand is exceeding the supply, and there's supply chain issues that are around reagents, machines, people to run the tests, the little pieces of plastic in the labs to run the tests, all up and down the whole path. So it's been a very challenging thing. It's really been prompted by the surge nationwide in cases, as well as the surge locally. We've been relying a lot on large commercial labs that are nationwide labs. So their surge in testing demand in Arizona and Texas and Florida is impacting their ability to test our local residents locally. So this is a real big challenge right now. We went into a strong shelter in place in March and April, and that really was effective in, flattening the curve, dropping the numbers. Our hospital numbers went from a peak of 44 down to between 10 and 20 patients in the hospital. It was effective, but it also had a tremendous cost, and no one really wants to go back to that. And so, our strategy going forward is to do, social distancing, hand washing, masking, protocols in place for businesses to reduce the risk of infection. And paired along with that is an aggressive testing and contact tracing strategy, so we can identify a lot of people early, get them to isolate, get their close contacts to quarantine, and break those cycles of transmission. But if we can't get this testing results back in a timely manner, it really puts that entire strategy at risk. So we're really trying every avenue possible to try to address this. We have escalated our concerns multiple times to the state. I was in conversations with our state health officer and the head of our California Department of Public Health as recently as this morning about this issue. As far as our capacity for meeting the demand for testing, we're adding weekend hours at our testing sites. We're looking at adding additional testing sites, including one at North Richmond, which we hope to open very soon. That will help address the demand for access to testing, but it won't address the concern about turnaround time with testing. We are actually testing now, finally, in the last week or so, above our target of 2 tests per 1,000 people per day. But other counties in the Bay Area are actually testing at a level of 3 per 1,000, or even San Francisco is testing at 4 per 1,000. But again, those tests will only be effective if we can get the results back in a timely manner. So to address that, we are working currently with contracting with several additional labs that are promising to deliver faster turnaround times. Some of those contracts will be coming to the next board meeting. We're seeking to raise the salary for our lab scientists so that we can be more successful in filling unfilled positions, so that we can run our machines multiple runs a day into the evening hours and on weekends, using additional staff so we can make the best use of the machine and supplies that we have at our public health lab. We're seeking to purchase additional machines at both our county hospital lab and our public health lab to add capacity. But many of those machines, everyone else is trying to purchase as well, and some of those orders are back ordered for months. We are trying to automate as many steps as possible in the process. These tests are very complicated. There's multiple steps that many of them are very manual for the lab scientists, and we're trying to automate as many of those as possible so we can maximize the productivity of our current lab staff. We're actually requesting a National Guard testing team. They've got a special testing unit that can come and this team would add about 100 tests performed per day, which is not a lot, but every little bit helps. And we're in discussions with them, and they might potentially be available as soon as next week. We are pursuing another open contract we have that we've used for mobile radiology, but they also have a lab arm that could be served under that same contract. And so we're working in discussions with them about pricing and capacity and their turnaround times. We're also working with the state to get additional of these rapid, what they're called Abbott ID Now tests. They're not as sensitive, so they generally need to be used with a confirmatory test, but they're useful in situations where you really need a test right away, like a woman coming into labor and delivery with symptoms and things like that. And so we're trying to get more of those. The reagents for these tests are still in short supply, so that's not going to be a short-term solution, but we know this is a long game with addressing this epidemic. We are working with all of our community partners. We have my team was on a call with our hospital partners in the last hour, and we've been pushing them. Kaiser, Sutter Delta, John Muir, all our different community hospital partners to ramp up their testing. They're also facing the same challenges. Our Kaiser lab in Berkeley is having a week or longer turnaround times for their labs as well, but we're pushing them to do as much as they can to work on this problem. We're investigating the technique of pooling samples, and that's where you would run, you take 5 or 10 swabs, you'd run them together as one test. If it's all negative, then you're done. If it's positive, then you have to test the individual swabs, but it could potentially add more capacity to our testing. It has to be, each individual machine has to be FDA approved for pooled testing. And so we're looking at the platforms that we have in our labs and when they might get approved for FDA approval for testing as pooled samples, and how many samples you could pool. We are using, the state has come out with updated prioritization schedule as to which tests to prioritize for the faster turnaround through our public health lab rather than sending them to the commercial labs. So that the highest priority is hospitalized patients and close contacts in outbreak investigations, for example, in a workplace outbreak or an outbreak in a nursing home. The next highest level is other patients with symptoms and high-risk asymptomatic individuals, including healthcare workers, first responders, close contacts of cases, and other routine testing of nursing home and assisted living facility staff that we're trying to do on a monthly basis. So we're trying to prioritize those to our public health lab so they can get tests ideally within a day, if not at least within 2 or 3 days. The state is taking a lot of steps. They've identified this as a priority across the states. They're trying to match up organizations that need testing to the labs that are still claiming they have additional capacity. They're also trying to pair some of these big labs with smaller labs so that the big labs can subcontract with some of the smaller labs that have extra capacity to run tests. The state's also looking at the lab staffing shortages, which many of these labs, both the public labs and the commercial labs, are experiencing shortages with the trained lab staff through some regulatory flexibility. So the state has waived some of their regulatory requirements, but the federal government hasn't yet lowered their requirements. So the state is having weekly conversations with the Center for Medicare and Medicaid Services, which oversees these labs, to try to get some flexibility there. State's also asking the labs to increase their frequency of when they are sending the results of tests into the state CalReady system, which is the reporting system for labs, which then our public health contact and case management teams pull those results out of. Many labs are just doing this once a day, and they're asking them to do it several times a day, so that, instead of maybe waiting till 5 p.m. to get a result, you might get that result early in the day, and you might be able to begin that case management and contact tracing, a few hours or a workday sooner. The state is also contracted with a developer of a new platform, a new testing platform, whose reagents work with over 20 different other commercially available machines, so that the state's hoping to ramp up production with this contractor of this platform and the associated reagents, so that the reagents could then be used in other machines as well. Many of the problems are, many of the current machines, there's only a particular reagent for that particular machine, and when that reagent becomes in short supply, then you can't use the machine, even though you may have reagents for other machines that you don't own. So this would allow a lot more flexibility of supplying multiple platforms of machines. At the federal level, one of our two large commercial labs that we contract with and send a lot of our tests to, Quest, they just got approved by the FDA to do batch testing. That was just on July 23rd. So hopefully that will help with Quest to be able to implement batch testing and get some of their turnaround times down. So again, this is a big issue. This is a big challenge, and we are trying to leave no stone unturned in different ways to try to address this and get our turnaround times back to a point where they can really be useful and effective and help break cycles of transmission. Moving on to talking about our current knowledge about treatments, there are several treatments now that there's good evidence that they are effective in treating people, especially people who are hospitalized and very ill with COVID. And I think we've seen some of the death rates from people diagnosed with COVID, which were 5 to 8% death rates early on in the epidemic, and they're running more, between 1% and 3%, depending on the different studies. Some of that has been due to better treatment. Of course, it varies tremendously by age, and we know the high mortality rate, even with these treatments, in our very elderly population. But the first drug approved by the FDA for treatment under an emergency approval basis is remdesivir, and it directly blocks the virus, the COVID virus. And the studies show that it does seem to help people get better quicker and cut their hospital stay by about 3 days. Still not clear whether it decreases mortality. The initial studies, it wasn't enough data on mortality to really prove that, but there was a suggestion maybe it might help mortality. It's been still in very, very short supply. The drug company is trying to ramp up production. The federal government is overseeing distribution to hospitals, and the distribution is being done based on recent hospital COVID census. So trying to proportionally deliver that drug to hospitals based on how many COVID patients they have. However, there isn't enough to go around. So, for example, in this past week, it's been delivered on a weekly basis. Our county, hospitals throughout our county got 28 treatment courses worth of this drug. And as Director Roth noted, we have over 100 COVID patients in area hospitals. Now, not all of those necessarily would meet criteria for treatment for this drug, but we've seen about half of hospital patients do meet criteria. So, and we've seen that the hospitals haven't had enough to treat every patient who's wanted them, and they've been really good in working together and sharing supplies when one hospital runs out and other hospitals have some, but there's still not quite enough to reach every patient who is eligible for that drug. The second drug to show clear benefit is one called Dextro Dexamethasone. It's a steroid drug. It's a generic drug. It's been around for a long time. It's very cheap and widely available, and it did show an improvement in mortality in sick and very sick patients who are given the drug. There's some less data about mild illness. It's not clear whether it really helps people with mild illness. In fact, some of the suggestion it might, in people with very mild illness, that there may be more harm than good. But for the sicker patients, there was clear benefit. Other things that we've learned on how to treat sick patients with COVID, including the use of blood thinners, because blood clots are a very common complication of COVID. And so treating patients with blood thinners to prevent blood clots is helpful. There's something called prone ventilation, where someone is on a ventilator. Usually they're lying on their back on a ventilator. And they've determined that rotating patients onto their stomach, even when they're on a ventilator, that helps with the fluid balance within the lungs and helps the air circulation in the lungs. And so that's a technique that's been adopted. There's some other techniques like using some high flow oxygen through the nose, through what we call a nasal cannula tube. For people who don't need to be on a ventilator, it seems to be helpful. Being very limited in the intravenous fluids and not overloading somebody with intravenous fluids also seems to be helpful. So there's a lot of different management techniques that these ICU doctors and hospital doctors have learned over time. Things we are pretty confident do not work is hydroxychloroquine, which the randomized controlled trials of this drug have been stopped. That there's no research, there's no legitimate research institutions or legitimate drug companies that are doing clinical trials in this drug, because there were a series of trials which showed absolutely no benefit in people with COVID. Similarly with azithromycin, there's been no benefit and no harm, and really at this point, when there's significant evidence of a lack of benefit, it's really unethical to do a study where you're offering drug to somebody that you know is not going to help them and could potentially harm them. There was some other early interest in some HIV medications called Protease Inhibitors. Those also haven't panned out to be of any benefit at all. So those are things that were, back in February and March, people were looking at, but they're clearly, there's been enough evidence now to show that they are not beneficial in treating the COVID, whether you have a mild COVID case or you're in the hospital with COVID. Finally, just to give an update on the school situation. So on July 13th, the state announced that schools, I think it was July 13th, it might have been July 20th, schools that were in monitoring list counties are mandated to do distance learning and not do in-classroom learning while they're on the monitoring list, and for at least 2 weeks after they fall off the monitoring list. As you know, we are a county that's on the monitoring list, as are most counties throughout the state. So our local schools are not allowed to resume in-classroom learning until, again, we're off the monitoring list for at least 2 weeks. The state did mention that they were going to set up a waiver process where elementary schools, and that's, the state's further defined that as K through 5 education, kindergarten through 5th grade, could potentially apply for a waiver if that waiver had the support of the local school superintendent, the local teachers union or teachers group, and the local parent organization, and the support of the local health officer to resume in-person education for elementary school. The state is still working on that process. They're promising to come out with a checklist that possibly may be out as soon as later this week, and also working on what are the criteria where a waiver would be supported by the state. One of the concerns we have certainly locally is that with our long delay in testing turnaround time, it would be very, very challenging for the health department to support a school if there were outbreaks, and certainly at the level of community transmission, it wouldn't be a matter of if, but when there would be outbreaks and cases at that school, to be able to support that school with testing and contact tracing with our current turnaround times would be extremely challenging. So we'd really want to see that our testing situation improve before we'd have a lot of confidence in supporting that kind of waiver process. But again, that is a process that is in development. We have received about a half dozen inquiries from schools interested in this, but the process is still in development. And then, that really brings me to my final point, is just a real plea to all the members of the community that, I think everybody wants to see kids back in school safely, and for the kids to be safe, and their families to be safe, and the teachers to be safe. And the best way we can do that is to really have everybody work together to, reduce the spread in the community by, wearing masks. If you're one of those rare individuals who can't wear a mask because of a medical condition, you wear a face shield, a clear plastic face shield. Protect yourself. We know that masks, now there's good evidence, not only do they protect others, but they also protect yourself. They reduce your exposure. If you do get exposed, you might get exposed to less virus, which might mean you might get less sick. Wash your hands, stay 6 feet apart, and especially avoid social gatherings, which we think, both locally and statewide are really driving a lot of the spread. So really avoid unnecessary social gatherings outside your own household so that we can really get our kids back to school and do it in a safe way. And that's all my remarks.
Okay, any questions, comments by board members? And if not, I'm going to quickly go to public comment to see if we have any public comment on this agenda item.
If there are any callers on the line who wish to speak on the COVID-19 update, please press #2. There are no callers on the line.
Okay, thank you. And we do always invite people to our Thursday 1:30 p.m. COVID ad hoc meeting. You can find that on the Board of Supervisors agenda page on our county page as well. Well, thank you very much, Chris and Anna, for that update. I appreciated that now that we're telling people they will have a benefit from wearing a mask. Previously, we just said it's how you help other people, but this is one of those logic dictates that if you're covered, you're less inclined to be inhaling or having any of those droplets hit you as well. So another reason to wear a mask. It's not just for others, but it's for yourself as well. So this will then bring us to the end of our Board of Supervisors